All right, let's talk about respiratory medications. This is one of those topics you just have to know, inside and out. We're talking about everything from a sudden asthma attack to a long-term fight against TB. So we're going to cut right through the noise and focus on what you absolutely need to know for your exams. Let's jump in. So let's start with the single most important question you have to ask yourself. Is this drug for right now, or is it to prevent problems down the line? This is the fundamental difference between a rescue medication and a controller medication. Honestly, if you get this concept, everything else will just click into place. It's like the difference between a firefighter putting out a blaze and an engineer fireproofing the whole building. But you know what? Before we even get into the drugs, we have to talk about simple physics, because the best medicine on the planet is totally useless if it just ends up on the back of someone's tongue. Now get this, without a spacer, a measly 9% of the medication actually gets down into the lungs where it needs to be. But add this simple little plastic tube, that number jumps to 21%. You've literally more than doubled the drug's effectiveness, not by changing the drug, but just by using the right tool. This is a huge point, so remember it. Technique matters. All right, on to Section 1, opening the airways. Think of these as the first responders of respiratory care. These are the drugs you reach for when someone is actively struggling to breathe, and you need to fix it like yesterday. So what are we actually trying to do here? Let's picture it. Your airways, your bronchi, they're basically tubes wrapped in muscle. And during an asthma attack, that muscle gets angry and squeezes tight, shutting down the airway. Bronchodilators have one job and one job only: to tell that muscle to chill out, relax, and let go. It's a direct mechanical fix to physically widen that pathway so air can get through again. Now, we've got two main ways of doing this. Over on the left, we have our superstar rescue inhaler, albuterol. This guy is a beta-2 agonist. It basically flips the relax switch on those airway muscles. It's a green light, go, go, go. Then on the right, you have ipratropium. It's an anticholinergic, and it works a little differently. It's more like a bodyguard. It blocks the nerve signals that were telling the muscle to squeeze in the first place. So think of it this way. Albuterol actively forces the door open, while ipratropium prevents anyone from trying to slam it shut. Okay, there is another bronchodilator we need to talk about, but you got to handle this one with care. It's called theophylline. It also helps relax those airway muscles, but it's often a last resort kind of drug. And there's a very, very good and kind of scary reason for that. And this number right here is the reason why. 10 to 20. That is the razor-thin margin where theophylline actually works. If the level in the blood is below 10, it's not doing anything. But if it creeps up past 20, you're in big trouble. We're talking seizures, life-threatening heart arrhythmias, a total disaster. This tiny little window between helpful and toxic is why this drug is so dangerous and needs super close monitoring. Okay, let's move on to Section 2, controlling the inflammation. So we've opened the airways and rescued the patient from the immediate crisis. That's great, but it's just a Band-Aid. The real long-term game, especially with asthma, is tackling the root of the problem, that chronic, simmering inflammation that makes the airways so twitchy to begin with. And this is where our controller medications come into play. The corticosteroids, like beclomethasone, these are serious anti-inflammatory powerhouses. Their whole job is to calm things down over time, reducing all that swelling and sensitivity. And this brings us right back to our main theme. Albuterol rescues you during an attack. A corticosteroid prevents the attack from ever happening. You would never, ever, ever use a steroid inhaler to stop an acute asthma attack. It just doesn't work that way. So what if your patient is prescribed both? This is a classic must-know exam question. What's the right order? You always give the bronchodilator first. Always. Use that albuterol to open up the airways nice and wide. Then you wait about 5 minutes, let it do its job. Then you give the corticosteroid. And the logic is just plain common sense, right? You want that anti-inflammatory medicine to get as deep into the lungs as it possibly can. And the only way to do that is if the road is clear. You got to open the door before you try to move the furniture in. All right, Section 3, clearing the path. Sometimes the issue isn't tight muscles or inflammation. Sometimes it's just gunk. It's a physical blockage from mucus that needs to be cleared out. So let's look at how we deal with that. So we've got two main strategies here. First, you have expectorants, like guaifenesin. These basically work by adding more water to the mucus, making it thinner, looser, and way easier to cough up and get out. Then you have mucolytics, like acetylcysteine. These are a bit more heavy-duty. They act like a solvent, chemically breaking down the very structure of the mucus, making it less thick and sticky. Both help make a cough more productive. They just get there in slightly different ways. And now, For Section 4, we're shifting gears big time. Let's talk about the war on tuberculosis. This is a whole different ballgame. With TB, we're not just managing symptoms. We are trying to kill a really tough, really clever bacteria. And that calls for a completely different kind of strategy. So why do we always throw a whole cocktail of drugs at TB? Well, there are two huge reasons. First, the TB bacteria is a fortress. It's got this waxy outer coat that's super hard for drugs to get through. But even more importantly, this bacteria is a master of disguise. It's incredibly good at developing resistance. If you hit it with just one antibiotic, you're basically just teaching it how to survive. So by hitting it with multiple drugs all at once, from different angles, we can overwhelm its defenses and dramatically cut down the chances of creating a drug-resistant superbug. So let's do a quick-fire round of the TB drugs you have to know. First up, isoniazid, or INH. For this one, I want two words burned into your brain: liver and nerves. It can be toxic to the liver, so you're watching for any signs of that. And it can cause peripheral neuritis, that awful tingling pins and needles feeling. And here's the key nursing intervention, and a super common test question. You give vitamin B6 along with it to help prevent that nerve damage. Next is rifampicin, and this one has a side effect that's impossible to forget. It turns all your body fluids, your urine, your sweat, even your tears, a bright red-orange color. Now, it's totally harmless, but can you imagine how scary that would be if nobody warned you? So your number one job here is patient education. Tell them it's going to happen, that it's okay, and super important, that it will permanently stain soft contact lenses. And our third big one is ethambutol. For ethambutol, just think E is for eye. Its major risk is optic neuritis, which can mess with your vision. Patients might notice blurred vision or, very specifically, have trouble telling the difference between red and green. This is serious stuff, so you have to teach them to report any vision changes to their doctor immediately. Okay, Section 5, your nursing priorities. We've just covered a ton of information, so let's boil it all down. What does this actually mean for you at the bedside? What are the key things you need to do and to teach? Here are your top priorities. Number 1, technique, technique, technique. Teach them how to use that inhaler and spacer properly. Number 2, they have to finish the whole prescription. No stopping early, especially with TB, or you risk creating resistance. 3, no alcohol. It's just too hard on the liver when combined with these meds. 4, know the warning signs. Teach them to look for signs of liver problems like yellow skin or dark urine and to call right away if they see them. And finally, number 5, smoking has to stop. It's like trying to put out a fire while someone else is squirting gasoline on it. And, that brings us to our final and, honestly, most important point. You can have all of this memorized, every drug, every side effect, every mechanism. But the number one reason therapy fails isn't because the drug is wrong. It's because the patient doesn't take it. And this is where the science of pharmacology ends and the art of nursing really begins. So the final question isn't just what does the medication do, it's how do I connect with my patient to help them actually succeed with this treatment? What's your next move?